Right, it's live now, Councillor Mason.
Thank you very much. Good afternoon, everyone, and welcome to the Health Overview and Scrutiny panel. I am Councillor Lee Mason, Vice Chairman, and I am chairing the meeting today. We are meeting virtually in response to the limitations placed on governance by the COVID-19 pandemic. Until recently, the law stated that all members had to be present in the room to make formal decisions at meetings. However, the law was amended in response to the COVID-19 emergency, and councils are able to hold public meetings virtually. This will be in accordance with the Local Authorities Coronavirus Flexibility of Local Authorities Meetings Regulations 2020, number 392. Members of the public are invited to view this meeting online. Those present are requested to keep their microphones on mute and to only turn them on when they are called to speak. Members are requested to keep their cameras turned on at all times. Officers are requested to turn the cameras on only when they are presenting their reports or answering questions. If anyone would like to speak, please write your name and RTS, which is request to speak, in the chat function. Each time you speak, please say who you are, and so clearly so we are aware of who is speaking. I'd now like to introduce those present to introduce themselves, our members and then officers and external representatives. I've got apologies from David Fuller, and I think we're all thinking of him today. I shall go through the list in the order I've got them here. Councillor Graham Heaney. If you just want to introduce yourself and say where you're from.
Yeah, I'm Councillor Graham Heaney. I'm from Apprenticeships ward, and I'm present. Thank
you much. Councillor Leo Madden.
Councillor Leo Madden, present. Portsmouth City Council, Nelson Ward.
Thank you much. Councillor Steve Weems.
Yeah, Councillor Steve Weems, Portsmouth City Council, Vaccination Uptake.
Thank you much. Councillor Tom Wood.
Hello, I'm Tom. I'm Councillor for Portsmouth City Council, St Thomas Ward.
Thank you much. Councillor Vivian Apple.
Yeah, hi, Councillor Vivian Atchwell, Winchester City Councillor and Whiteley and Shedfield Ward.
Thank you much. Councillor Arthur Agate.
Good afternoon, Chairman. Arthur Agate, East Hants District Council, and I declare no interest in any items to be discussed.
Thank you much. Councillor Trevor Cartwright.
Yes, good afternoon, Chairman. I'm Councillor Trevor Cartwright from Ferren Borough Council, Deputy Leader and Executive Member of the Health and Public Protection. Also, Chairman, I'm afraid I'm going to leave the meeting at 4 o'clock because I have a regular Thursday afternoon meeting at 4 every Thursday, so apologies for that.
I'm hoping we'll all be left by 4 o'clock. Thank you much. Councillor David Keast.
Yes, David Keast, representing Hampshire County Council, the Vice Chairman of the Health and Overview Committee.
Thank you much. And Councillor Philip Raffaelli.
Good afternoon, Councillor Philip Raffaelli, Gosport Borough Council representative. Thank you.
Excellent. Thank you much. And I've got apologies from Councillor Rosie Rains, Havant Borough Councillor, and she passes on her good wishes to everyone and hopes they all had a good Christmas and a New Year. And also apologies from Councillor David Fuller, as been previously mentioned. If we go through the officers and external representatives, so hopefully you're all here. I've got on my list, I've got Susanna Rosenberg.
Good afternoon, Susanna Rosenberg, Chief Operating Officer for Solent NHS Trust.
Thank you much. I've got Sarah Rees.
Sorry, Councillor Mason, I've followed them up. They are meant to be joining, so I'll keep contacting them, but it is in their diaries.
Okay, is Richard Samuel here?
Yeah, he's meant to be attending along with Sarah Rees.
Okay, thank you much. And Anna Martin, if you'd like to introduce yourself as well.
Yeah, Anna Martin, Democratic Services.
Thank you much. Is there anyone present who would like to make themselves known who haven't called already? No.
Get the impression Councillor Mason's frozen.
Team seems to be having a bad day. It just chucked me out for seemingly no reason, just closed. I'm not having any of that.
Oh, yeah. my laptop decided it was a brilliant time that it had a problem and it needs to restart. So I have lost my script now because I was using the tablet for that, and I'm now on the tablet. So apologies for that. Can you all see and hear me okay?
Can we only hear you at the moment, Lee? Can't see you.
Can't see me?
I can see you, Lee.
Yeah, I can see you okay. We could.
I can as well.
Oh, yeah.
I can see you.
All right.
Yep, I can see you too.
Okay, good. So we've just done apologies, declarations of members' interest.
Sorry, Lee, you've just gone again.
Can't see you now, Lee.
Can you see me again?
Yes.
Yeah, that's fine.
Right. I'm going to try and get my laptop going again as well, so I can actually get the minutes. But in the meantime, do we have any declarations of interest? I don't think there have been any, but...
Yes, Mr. Chairman.
Seems...
I work for the NHS, and so I have a personal but non-prejudicial interest as I work for South Central and West CSU.
Okay. Is there anyone else got any declarations to declare? No. In that case, moving forward, I believe it's minutes next. Anyone wish to make any comments on the minutes? No. In that case, can I have a proposer for accuracy, please?
I'll propose.
I'll propose.
Councillor Leo Madden, thank you much. And seconder, please.
I'll second if you like.
Thank you much. Councillor Graham Heaney. And apologies for the delay, but I've got to go through the Cisco council security to get back on there. Sarah Rees and Richard Samuel due to join. Okay, so they are en route. Are there any matters arising from the November meeting? In which case, if we go to agenda item 4, can we have Rosenberg, if you'd like to do the introduction, please?
Good afternoon, councillors. I am wearing a mask because I'm at St Mary's at the moment, so hopefully you can see part of my face. So I will assume that you've had an opportunity to read my report. This is the regular update from Solent. It is entirely focused pretty much on our COVID response, as you would expect. And there were some attachments which hopefully you were able to access either by PDF or by a link, which I thought would be really helpful for you to see as information in terms of some of the lessons that we've learned from the first wave and how we are taking that learning forward as an organisation. We have a number of those, and I just put a couple of examples in for you. So very happy to take questions on anything that I've put in the report.
Thank you very much. Does anyone have some questions they want to? I can see Councillor Weems first.
Thank you, Mr. Chairman. Yeah, I can see that there are a number of lessons, or I'm pleased actually to see some of the things that have come out of the COVID response, not least of which is empowering staff on the front line, which has always struck me as actually a good way for organisations to proceed, even when things are more normal, when there is business as normal. And I think the question I have is, what lessons will be learnt from this once we're through the worst of the pandemic? I can't say we'll ever lose it entirely. Sorry, not me, I hope. Somebody's got their microphone on and getting feedback, I think. Anyway, sorry, Ms. Rosenberg. What I was trying to say was, clearly staff on the front line have been empowered. How will those lessons be translated to the future when we are through the worst of the pandemic and back to business as usual?
Thank you, Councillor Weems. A really good question, and I'm guessing I don't know all of the answers to that. I think what we are going to try and do is make sure that we don't lose any of the learning, which is why we've decided to take the approach that we have in terms of our research department putting together those valuable learnings. I mean, we have found that during the first wave, our operational delivery was completely transformed in such a short period of time, and most of that was led by the staff. They were the ones who came up with the good ideas. They were the ones who came up with the art of the possible, and being able to put that in place, like you say, has really empowered them. And so I think as managers and leaders of these services, we will want to make sure that we listen to our staff, because they are the ones who make sense of it much quicker than we do. Sometimes when we get together as managers and sit in a room, you know, we spend hours and hours talking about stuff, and they could have done something much quicker. So I think it is that two-way conversation.
Thank you. Sorry, Mr. Chairman, if I may, I think it's a lesson for all organisations, our own councils included. It's empowering frontline staff actually makes organisations run better, in my view. Sorry, I don't know if Councillor Mason's still there or not.
Councillor Madden's muted.
I'm still here, yes. Sorry. I've got Councillor Raffaelli and then I've got Councillor Madden.
Thank you, Chairman, and thank you, Susanna, and thank you so much to you and your staff for everything that's going on just now. And it's remarkable what you've achieved, and it's remarkable that you're here today for this event. A couple of things, if I could pick up on. One is indeed about the learning, and it was interesting to note the specific comments about leadership and the need for leaders to be developed and also improve their ability to focus on their staff. I think you've picked that up, but that will be an important one going forward. I have a slight nervousness about some of the lessons learned. There's a fair part in the papers, your papers, about different means of having patient consultations, and there's been a lot written about this and a lot in the press and from patients' organisations and the rest. There is no doubt it has enabled a huge amount of very good practice. But when the Secretary of State said it should become the default way as we move forward, I think there was a sharp intake of breath from many of us and from many of the colleges and presenters. And the figures that you've given, I think, are very interesting. It is good for some things, very good for some things, and very good for some people. But it's not for everybody. And the only note of caution I would make, because I see it absolutely being part of the normal practice as we go forward, is that during the pandemic, I think people have been prepared to accept and recognise the challenges that the NHS is working under. And it may not be quite so much what they're prepared to work with as we move forward. So whilst I'm very pleased to hear you saying that you've got the people, the researchers looking at the lessons to learn, in some areas, I would just suggest there should be a slight pause to see how things restart as we move towards normality before going absolutely final on something. So it's that was more of a comment. But I do have two questions for you, if I may. You do mention about your staff were fortunate to get vaccinations. I think it should be more positive than that. Do you have an update since the report on how well your frontline staff are being vaccinated? Would be the first question. And the second one, you very much recognise the mental health issues and that you're developing a plan to transform the mental health service delivery. And it's just to say that that transformation is something I'm sure we would all like to see before it's actually moves towards implementation. That was my two questions. Thank you.
Thank you, Councillor. In terms of vaccination uptake, we think from a Solent perspective, we're at 60%, with another 15% who have appointments booked, but we just haven't been able to fulfil those quite yet.
Well, that's quite
so we hope in the next few days we'll be up to 75%. In terms of the mental health transformation, nationally it has been paused, which is probably the right thing to do right now. And absolutely be very happy to bring it back to HOSP.
Thank you, Susan. Thank you.
Thank you very much. Councillor Liam Madden.
Thank you, Chair, and welcome, Susanna. Mine is more or less the same points that Philip has been making about the direction seems to be one of remote consultation. I've had it, I have to say, prior to COVID, and I didn't like it. I was told that's all I could do was for a GP to contact me over the phone, which we did, and it didn't satisfy me at all. But there's an interesting bit. One of the comments in here says, we've been providing the service to the best of our ability, but we're all feeling uncomfortable that we're not providing the service we'd like to. I miss the luxury of face-to-face, and that's a strange word in that context. But however, it's okay over the phone, but the rapport with the patient is slightly blurred. Now, no patients are complaining of lack of face-to-face, but I think it would be better. They're not complaining, as Philip said, because people understand the situation we're in and trying their best not to use the NHS. So I would just like. There will be clearly loads of reports coming out post the pandemic from all sorts of areas, but I do hope that in this area that it'll not just be jumping into remote rather than face-to-face, which I think anyway, and I've said this before, particularly in mental health services, is very important.
Absolutely, we won't. I can assure you that we won't be jumping into remote as a default across the board, and we are still doing face-to-face. So most of our patients can still have a face-to-face if it's appropriate, like you say, Councillor Madden, particularly mental health and particularly older people with mental health and people with hearing or visual impairments. So I think we will want to, when the dust settles, I think we will want to assess each and every service line and see what is most appropriate and have a blended approach.
Thank you very much.
Okay, thank you.
Is there anything further, Councillor Madden? Or?
No, I did say no, thank you.
Okay, thank you very much. Councillor Steve Weems, please.
Yes, thanks, Chairman. Sorry, it takes a moment or two to get the mute off. I actually just want to come back on Councillor Madden there. Well, go to Ms. Rosenberg. I can understand exactly what Leo is saying about mental health. And I think we have to address the issue of the patient as whether a remote, well, non-face-to-face consultation is appropriate. Because I know that for GP services, doing things remotely actually allows GPs to increase their productivity by up to 50%. It's quite colossal sometimes, some of the increases in efficiency that can be achieved. I do accept there are some things for which GPs do need to see their patients, but on the follow-up appointments, it's not always necessary. As I say, it has to be tailored to the patient, but I do think we shouldn't just dismiss remote service to patients. That's all, Chairman. Thank you.
Thank you much. Did you want to come back on that? I've got Councillor David Keast.
Thank you, Chairman. I don't know if I'm sure that other members have the same problem, but I have an area of deprivation in my ward, and if I get when I visit the community centre on a regular basis, they are telling me there is an increasing number of people with mental health problems who need help, and they can't get it. There's a lot of pent-up demand, I think. How are you going to cope with this, particularly if not now, when COVID is over?
Really good question, and we are making plans to cope with what we think will be a mental health sort of mini epidemic, if you like. And we think that we will see that through Positive Minds and through Talking Change and through GP referrals in the first instance, rather than admissions to our wards. So we are looking at how we can increase the capacity of those services as we go forward to cope with that. Positive Minds has been continuing to operate throughout the pandemic. Obviously, they have had to close down their building in the centre of the city. But part of the transformation plan that I referred to in the report is about expanding those frontline services and those first point of contact services. So there is going to be an injection of funding into the city to expand that.
Can I come back, Chairman?
Yes. Yeah.
Thank you. Will you be contacting these places like the community centres so that they can actually give you an idea on what help they need?
So I can certainly pass that through to Positive Minds, because they are the people who they're run by Solent Mind, and they are the ones who are making links to all of our community support providers. So that's a really good suggestion. So I will pass that on, Councillor.
Thank you much. I've got Councillor Steve Weems.
Thank you, Chairman. Just a very brief question, Susanna. You mentioned an increase in funding, and that's obviously fairly welcome. But will that increase in funding be able to address any delays there is to mental health patients receiving treatments? Because sometimes, for some patients at least, delay can be very serious. I'll leave it as remote as that. But obviously, if you're a mental health patient, the problem doesn't go away, and the issues are probably fairly immediate for them.
Yes, absolutely. Time is of the essence, like you say, Councillor, and the transformation is set to address that. So people at their first point of contact get put in touch with the service that can provide the best support at the most timely point in their journey. So the investment will be about both increasing the range of services and the timeliness of services, supporting primary care as well.
Thank you.
Thank you much. I haven't got anyone else in my list at the moment wishing to ask a question. I can't see any hands. Is there anyone else with questions? No. In which case, I think this report is just for noting. Can I thank you very much for coming in, Susanna. That was very useful, I think, report to hear back, and thank you for answering the questions. You're more than welcome to stay for the rest of the... Oh, sir.
I don't know if you spotted, Chairman, but the late Richard Samuels has arrived.
Yes, yeah, I press admit. Thank you. You're more than welcome to stay for the rest of the meeting, but we understand if you've got other things to do at St James's. But thank you for attending today.
Thank you very much.
And good timing there. Moving on to item 5 on the agenda. Update from NHS England on dental practices, which is page 35 of the pack. NHS England send their apologies, as unfortunately they were not able to send a representative to the meeting today. due to a number of staff changes and sickness. The new senior commissioning manager for dental has caring responsibilities on a Thursday, so was unable to attend to answer questions on the update. Have members got any questions on the report that they would like the committee clerk to email them in the meantime?
Chair, could I just move that we note the report?
Yep. Everyone happy with that? Okay, moving forward. Item 6 on the agenda. Sarah Rees and Richard Samuel to give a brief update on the report of Sustainability and Transformation Partnership. This is page 37 of the pack.
Thank you, Chair. I think Sarah Rees was going to start on an update on the STP ICS, and I was going to pick up on any matters relating to the NHS response on COVID-19. If you're content with that.
Yep.
Hello, it's Sarah here. Thank you very much for your time. Sorry, I'm not on screen. I'm sharing the Wi-Fi at home with a number of other family members, so apologies for not being able to transmit on camera, but thank you very much for having me, so to speak. So we circulated a paper as part of the pack that summarised our journey to date to evolve from what was formerly known as an STP, the Sustainability and Transformation Partnership, into what is now referred to as an ICS, an Integrated Care System, trying very hard to avoid jargon, but verging on impossible, unfortunately. And so we've circulated that paper, and I understand from Anna that you might find it quite helpful to, rather than page turn those 12 pages, you might want to pick out some specific points for further discussion. But if you would find it helpful for me to give a little bit of a high-level summary, I'm very happy to do that. What would you prefer I did, Chair? Would you like a bit of a high-level summary, or would you like to go straight into any questions and discussion?
High-level summary, unless I'm just looking around the screen for, yeah, had a few notes on that high-level summary, please.
Lovely. Okay. So assuming colleagues have access to the document and have maybe had an opportunity to flick through the papers that we've circulated. So we've talked on a number of occasions over recent years in this forum about the work that we're doing together as primarily NHS and local authority partners across the whole of Hampshire and Isle of Wight. And this work is to complement that work which is done more locally, more effectively more locally by local partners. So the City Council, Hampshire County Council, working with the local hospital trust and with other providers of services, so Solent, NHS Trust, Southern Health, also providing mental health and community services in the wider area, and other partners. And so what we've done within the document circulated is we've sought to bring you up to speed with some of the work that we've been doing to mature, to further evolve, to further develop those arrangements for that work that we do together at a whole Hampshire and Isle of Wight level. And so the paper sets that out. What we've done over the last few months is revisit our vision for working together across Hampshire and Isle of Wight. And you'll see on page 7 within the pack, that describes the vision for working together at the scale of the whole larger system. So together working to deliver care that's amongst the best in the world, enabling people to lead healthy and independent lives. And that will indeed resonate with the local vision that no doubt you will have at a very local level, and all partners also, reflecting that ambition to provide the best possible care that we can, working in partnership to support the people, to support our local population, the people that live within our geographies. And so within the document, we also go on to expand, describe in a little bit of detail how it is that we're working with and involving local people. And again, you'll see us describing there the fact that we absolutely understand the majority of that involvement, co-production, co-development, joint working with local populations is absolutely best done in the local area through local partnerships. then at a Hampshire and Isle of Wight level, there's a layer of involvement that just brings all of that together and adds a level of richness to your more nuanced and local detailed conversations and work with local people to understand what they want, what they need, what they expect, and how we can work increasingly effectively together to work with them to meet those needs and expectations. And then moving on through the pack, we describe on slide 9 the anticipated impact for local people of us continuing to work increasingly effectively together on a handful of things at scale. So we point to some very recent examples of that work where partners across the patch have worked together to support each other in this unprecedented time in terms of supporting hospitals across the patch to deal with unprecedented levels of urgent and emergency care, supporting those with COVID, but also those without, and sustaining services as best we can. You can see our references in there to ensuring that we have new services such as NHS 111 first working effectively so that we can continue to care for people in the most effective, quickest and safest way possible in the midst of the pandemic. And you can see that whilst we know that the pandemic has further widened some of those inequalities that exist within an area, but across the whole of Hampshire and Isle of Wight as well, we know that there is work that we can do very well together as we work through the next few months and as we come out the other side of COVID, as that vaccine rolls out and takes hold and helps us to recover from the last year's weather events. So we know we've got a lot of work to do there to close those inequalities, to be clear about who have been disproportionately impacted by COVID and how we might work with those communities to address those inequalities that have widened over recent months. And you can see there on page 9 just a snapshot of an example there as to how our work together has helped us to support a particular individual who was very frequently interacting with services, but by working together we've been able to support him as a particularly vulnerable individual and indeed support those services that were interacting with him on a very frequent basis to provide for him effectively, but also to ensure that effective use of their services. And then towards the end of the pack, just a minute or so more on this. So towards the end of the pack, on slide 10, we try to describe in diagrammatic form the key elements of the Hampshire and Isle of Wight system and how those elements of the system, how those partnerships within our system come together to transform, to develop, to sustain services for the population. And on slide 11, we've summarised our people plan, which talks about our workforce, our shared workforce across Hampshire and Isle of Wight, and a number of things that we're doing together to look after our people and to develop new roles and new ways of working, new ways of delivering care, and making sure that we grow our workforce so that we have the right people, the right staff in the right place with the right skills for the future. And then finally, a slide that summarises our next areas of focus as we continue to develop our work together.
Okay, thank you very much. I've got Councillor Raffaelli has put in to do a first question.
Thank you very much, Chair, and thank you for the presentation. That was very helpful. One general comment first, if I may, Sarah, before I get into some specific questions.
Mm-hmm.
Of course, the STP was initially a plan rather than a partnership, and one of the benefits of a plan is it gave us clear visibility of targets and timelines and financial consequences. We've talked about this before. This kind of presentation, particularly during COVID, is very understandable, but what it doesn't do is give us specifics that we can actually properly understand and oversight and scrutinise. But that's an intro. As I said, I do have a couple of specific questions, if I may, and I'll just put them all together because they're relatively short. With the 6 CCGs coming together, I take it that means you've overcome the financial and legal challenges for combining and sharing budgets. You do mention there'll be local teams. I wonder if you could say just a little bit more about the sort of size of these local teams, what kind of autonomy they'll have and how they'll interact with local patients and others. The second thing is you mentioned virtual wards. It sounds a really interesting concept. Again, could you just say a couple of words about that? The Apprenticeship Academy is similarly interesting. What kind of scope and quantity do you expect that to cover? What particular roles are you going to be undertaking to train? And the final thing is you do mention an ICS assembly. Could you say a bit more about the plans for that and you anticipate being involved with that? I could go for it if it goes on, but that's it. Thanks very much.
Lovely, thank you very much for those, and I'll be able to provide a varying level of detail on some of those. Some of them I'll need to come back with some follow-up information after the meeting if that's acceptable to colleagues that we do that. So picking up on each of those points, so in terms of the local commissioning teams, so the work that we're doing currently to describe what those teams look like is very live, and so some of the detail is yet to be pinned down. But essentially, the starting point that we're working with is that we have had the benefit of 7 CCGs across Hampshire and Isle of Wight for quite some time now. And clearly, in the midst of the pandemic, we wouldn't want to disrupt those ways of working, those teams, and impact on their ability to do what they need to continue to do to support local colleagues, local partners, health and the population more broadly. So we're very mindful of this being a particularly challenging time to make major changes. But actually, those starting points for many teams will remain the case once we pass through this pandemic. So we absolutely expect to have teams that focus on your particular geography, as indeed will be the case for South West Hampshire, Southampton, the Isle of Wight and Northern Mid Hampshire. And so we're still working through the level of detail in terms of the autonomy, the size of the budget, the decision-making framework within which each of those teams will operate. But our starting point is to work with the teams as they currently stand, the level of autonomy that they currently have, and we will only draw together those elements that make best sense to do once across the whole of Hampshire and Isle of Wight. But for the time being, our starting point is the current way of working and the current configuration of teams, with that detail to be worked through over the coming months, but in particular as we head into the next financial year, April onwards, which will coincide with clearly us moving on to a different phase in terms of the pandemic. Richard, I'm mindful you're here on the call with us and may well have some additional detail to offer on a number of these points. So please do let me know through some hand signal if you have something to add on any of these. Moving on to the point around virtual wards. So essentially the way in which these operate, and I think a number of colleagues, Suzanne would have been able to talk about some of this in detail if she was still with us. So essentially the virtual wards are very much, as they say, virtual in nature. So for general practice, typically we identify patients that would benefit from some closer support, closer monitoring from primary care colleagues, or it may indeed be through colleagues operating out of the community trust, the community provider organisations that would closely monitor those patients who remain at home and are very safely and closely monitored at home. And where appropriate, we provide them with equipment to monitor their oxygen levels, for example, so that we can be really clear as to the sort of day-to-day, hour-by-hour status of each of those patients. And our colleagues, particularly in primary care, are able to pick up the phone, contact, support, visit if they need to, although of course we are minimising face-to-face contact where possible. Any patient that needs something that little bit more intensive in terms of health and care support as they convalesce at home, if indeed they find themselves, for example, with COVID or some other condition that requires just that bit closer monitoring. Moving on to the apprenticeships, I must confess this is one area where I'm far less close to the details, so I can come back to you on that unless Richard had something on that. I know Richard's got his hand up, and then I'll finally go on to the assembly. But Richard, apologies if you were putting your hand up on my previous point about virtual wards.
Sorry, Chair, I just thought I'd give you the Portsmouth City numbers, if that was helpful. So we have, as of today, we have 70 people who have been into Portsmouth Hospital, who have been assessed in the same day access service, and then sent home with a pulse oximeter to monitor their oxygen saturation, and that will give them an immediate return back to hospital if the hospital feels that their oxygen saturation is dropped and there is a risk of silent hypoxia. We've also got 110 people who are being managed in what's called community oximetry at home, and that's where the GPs will give a patient a pulse oximeter, and they'll do the same thing, but the GPs and primary care will manage them. So in total, at any point in time, we've got 180 people who are being managed either by the hospital or general practice with pulse oximeters in Portsmouth City on that basis.
Thank you. And are these remotely connected, or are the patients reading them regularly and advising on a cut-off number of 90?
Yeah, so the latter. We looked at whether we could have a digital monitoring, and actually concluded that it was probably best to have the patients to keep a diary effectively of their pulse oximetry. So it's, in that respect, it's typically only suitable for individuals who are comfortable with the technology and able to keep a diary effectively, and or have a partner or carer or individual who's able to do it on their behalf.
Thank you very much. They do have it about item about it on BBC South Today as well, the rollout of oximeters. So I did learn that 92% you tell them to go straight to hospital, and 93, 94 you're advising them to make contact. So anyone who wants to watch it, they can catch it on the news later. I've got Councillor Leah Maddens asking a question, followed by Councillor David Keast.
Sorry, there was a couple of other points. Oh. Sarah just paused on to ask for Richard's input.
Oh, sorry. Yeah.
So the final point I was going to pick up was the assembly. So as we refer to within the pack, so
Sarah, you were going to a little bit more about that. You'd asked Richard about the apprenticeship school, and then you were going to do the assembly.
Yes, sorry, can everybody hear me, or am I still on mute?
We can hear you a little bit.
Yeah. Okay. So the assembly, as we've referred to in the pack, so the assembly itself is something that we have the sort of precursor arrangements already in place for. So we had 2 whole system summit meetings the year before last, which drew together a very wide cast list, a variety of colleagues from a number of areas, and indeed all across Hampshire and Isle of Wight. So as we refer to on the slide within the pack, the concept of the assembly is that we would, in a very inclusive way as opposed to exclusive way, draw together colleagues from political, clinical, executive and community leadership roles, and bring that group of people together as an assembly a number of times a year. Twice per year is the proposal, for that group to operate in an advisory capacity. So the ICS Partnership Board, the Integrated Care System Partnership Board, will convene as a smaller group and more frequently throughout the year to develop, oversee, drive strategy, for example. But we would test with that assembly the content of that strategy. We would report through to that assembly to contextualise those conversations and those discussions, progress. So very much relates to your previous point, or your initial point, Councillor Raffaelli, about a plan and then the oversight of the delivery of those plans. So using that assembly in a slightly more informal way to test, to refine, to support oversight arrangements and to support involvement, and also to support the alignment of our work with that which is led at a more local level by a range of partner organisations, including local authorities at the various tiers, including community and voluntary sector groups, Health Watch, for example, as well as NHS partners and other partners that operate in the system. So, as I said, we had 2 meetings referred to as whole system summits the year before last. and that was very much us experimenting with this sort of forum, and with a view to establish something along those lines during this calendar year, but again, pandemic dependent in terms of how we go about doing that, whether that's something virtual. And I would imagine, as with a number of elements of our proposed governance and involvement arrangements, we will further iterate and refine these ways of working over the coming 12 to 18 months.
Thank you.
You're mute.
Thank you. Councillor Leah Madden.
It's a good thing I had my mic on. Thank you very much. Thanks very much for that presentation. The predecessor to this unit was, as Philip said, the STP, plan, partnership, whatever you want to be, which were I think it's the same defined region, was given a sum of money. I think it was near enough half a billion. Defined and therefore set up partnership work, and we've seen some good examples of that. But is there still a target to find savings from government?
So, as is ever the case, we have a financial envelope to live within, and as is unfortunately often the case, that financial envelope is smaller than is ideal or would be preferred. So, indeed, there absolutely will be work to do to ensure we're using those every pound that comes into the system, however it arrives and through whichever organisation in the system it arrives, as effectively and as efficiently as possible. And so, yes, there will be a need to identify further efficiency opportunities. Again, and I hate the fact that I'm constantly caveating everything I say with a reference to the pandemic, but of course it has a very significant bearing on the financial picture for us. As it currently stands. But yes, there will inevitably be further work to do to identify more efficiencies going forward. But equally, what we've learned about ourselves across all sectors over the last 12 months is that we can be incredibly creative and innovative, and we can find extraordinarily efficient but also effective, safe ways of supporting and working with our people, and we have a lot to learn and a lot to use a bit of jargon, lock in terms of how we've worked over the last 12 months in particular. And some of those new ways of working will be something that everybody involved, those receiving services and support, those delivering those services, will very much want to lock in as a new way of working. There'll be other elements that we may well want to revert to previous pre-COVID ways of working, but there's an awful lot that we've learned about ourselves and what we're capable of as people and as staff, and we want to make sure that we hold on to all of those benefits, absolutely not just for the financial reasons, but for the other benefits that has delivered.
Well, thank you for that answer. I don't think you added anything to what I didn't know, Sarah. I mean, mine was a simple question. I mean, we had a target of, let's say, $500 million before. You say there will be a target, so we'll know at some stage. I mean, I can see with this, and so I have to say there's some very good work had been done pre-pandemic, and clearly from this and from Susanna Rosenberg's report, a lot of good work's happening at the minute. But I was just wondering if you are going to, I don't use the word constrained lightly, by a target that's been set as it was before, where deadlines were given and missed. So, I mean, I don't want to, I hope we're not in that sort of straitjacket with the current organisation. That's the point we make. So at some stage, government will say, you have to save or find savings of this amount or by this amount. Is that correct?
I can see Richard wants to come in here, so I feel I should refer to Richard.
Yeah, so thank you, and Councillor Madden, you're absolutely right. This year is no different to previous years, although the environment of the financial environment around which the pandemic has played through has fundamentally changed the way in which the financial flows have operated. So instead of an allocation at the start of the year, what we've had is the revenue costs associated with the pandemic identified mid-year through and then projected forward, and then each system is asked for the rest of this year ending March 21 to live within that revised financial envelope. So the envelope we started the year with is fundamentally changed. Some of the rules have changed, so we haven't got a responsibility to pick up long-term care costs for CHC, for example, this year, but we will do next year. The headline is for Hampshire and the Isle of Wight. At this stage, we believe that we are within £5 million of hitting that year-end £2.5 billion target. Again, it's changing each month, and the levels of pressure placed upon services and new workforce. But and that is accepted by the regional team, and they have welcomed that progress. So that leaves us at the end of the year, financial year, with a very minor deficit against the scale of revenue position for Hampshire and the Isle of Wight. And we also believe that we will hit against our national allocation of capital, which was just under £100 million, and we believe that we will live within our capital allocation as well. Next year is a different matter. We understand for the first quarter of next year, we will see a rollover of a quarter's worth of last year's allocation for the first quarter, prior to then a reset of budgets after the first quarter of 21-22, where we will understand what allocation we'll be receiving. So at the moment, the ambitions centrally and from Treasury is to cover off the costs of the NHS as they are incurred within a reasonable sum. From quarter two onwards, we are awaiting guidance as to what the nature of allocation will be for the NHS, but we anticipate clearly that it will not be on a so full stop. The only two other big things which is worth the committee being very clearly aware of is that we've seen now very significant trails that the traditional fee-for-service model in the NHS will be changing. And you know, you've heard of PBR, which is the predominant means of money flow within the NHS, certainly for acute sector. The view is that we'll be moving away from a fee-for-service payment by results model to one built around outcomes, and therefore organisations and systems will work together to determine the optimal deployment of money to improve outcomes, reduce inequalities, rather than it being you do something, you get something. And again, we have had that trailed, we haven't seen the formal guidance. So we're in a little bit of uncertainty. The final thing to say on the money is, of course, we have by necessity had to increase our workforce this year in order to cope with the level of challenge we faced. And that has increased our permanent workforce. It's covered this year by the increase in revenue into the NHS. And as I said, we're within £5 million of a balanced position for health in Hampshire and the Isle of Wight. We need to work through what that plays through in terms of recurrent revenue cost for Hampshire and the Isle of Wight post-pandemic.
Okay, thanks for that, Richard. Yeah, we've had special or one-offs, I can put it that way, on the old STP, and as things develop on this, and after the pandemic, perhaps we could do that again and get more up to speed with it. I just have a couple of questions relating to specific points in the report and concerns. That's all. But no doubt you said on page 3, on the third bullet point, it says increasing hospital discharge schemes to ensure local people are discharged from hospital as quickly as possible when they are clinically fit for discharge. This has been a bugbear, obviously, of this committee for some years, you know. So, and we've been given suggestions as to how people could be discharged. But in the current circumstances, there's a word that seems to be missing to me. That's all, and the word is safely. Because, you know, we have these stories of people being discharged from hospital back into care homes, for instance, and passing it on. So no doubt you assure me that that is the case, so we can put it in the minutes.
Shall I pick that up, Sarah? So absolutely, the ambition and indeed national guidance around the discharge protocols have been written in such a way as to ensure safe discharge. So there's a designation of beds which are fit for discharge of COVID positive patients, and a full testing regime, including 2 negative tests in the 48 hours prior to discharge. So the whole process is now geared towards infection prevention control, safe discharge. what we always, and there will be, there is inevitably huge challenge presented in the hospital sector in working with all the discharge locations, which are changing almost daily. So if you have an outbreak in a community setting, that capacity closes and other capacity is brought online. So there continues to be a hugely sophisticated set of arrangements in play around standing up community capacity to support discharge and maintaining that capacity given workforce shortages, COVID outbreaks, and matching the needs of the patient to the needs of the facility. So to give you an example, we've just brought online Spire Portsmouth as a discharge facility for the local patch, which is brilliant. We're really pleased with. But that typically is suited only for the discharge of green, i.e. non-COVID patients who have low acuity. And at the moment, there aren't that many of that cohort of patients in Portsmouth Hospitals Trust awaiting discharge. Most of our patients are COVID or recently COVID positive or more complex or higher acuity. So yes, the answer is there is a commitment to and to ensuring absolute safe discharge. There are rules around discharge of COVID positive patients into designated settings, but I wouldn't underestimate the complexity of maintaining flow in this complex environment.
I think the short answer, Richard, was yes, you will only be safely discharged.
Yes.
From hospital. Yes. Okay. Thank you. Good. And my very last one is just on the next steps. And a keen focus on the wider determinants of health, such as housing and employment. And just say, Richard, probably even before you were born, I sat on a committee in the early 90s, and guess what? Two of the issues to be addressed were employment and housing. Along with smoking and drinking and all the rest of it. And nothing clearly, and we also could determine then, 30 years ago, what part of the region, the sub-region, was better to live in because you'd live longer. So in what sense, what can you do? What can the IC, whatever, do? Obviously, if it's only a paper exercise, which it clearly was then because it wasn't followed through, but you can, and particularly housing, social housing and private housing as well, we do, as local authorities, do our best. But I just wonder what your unit will do to make sure that people will be living in better housing and there'll be more employment opportunities. It sounds a bit cynical, but I am slightly cynical on this one. Thank you.
Maybe Councillor Madden, I can send you through the work we've done around housing to date, because actually it's been nationally recognised locally. It's not ambitious. I know Councillor Raff we've been endeavouring to support fragile or vulnerable tenancies, particularly where those correlate with people with mental health needs, so that we have trained a raft of mental health first aid workers within the housing sector, so that if they need, if we think that there are vulnerable tenancies associated with patients running into mental health distress, then we can act early to keep people in their home settings, to reduce homelessness and keep people in their settings, because we recognise actually that the safest and most valuable location for anyone to receive to promote their health is in their own home. So that's been the predominant focus of our work, is to sustaining people in vulnerable tenancies, to building the capability of the housing workforce, to spot and manage crisis, and then putting early response teams together to respond rapidly where we think we've got concerns about people moving into homeless settings. We're also worrying and focusing on individuals who are homeless as they present into urgent care settings, and where they are, we then work with local authorities in situ rapidly in order to find suitable alternative housing locations, because again, homelessness is a key driver of the presentation of health needs. So you're right to be sceptical, I think, rather than cynical. I think you're right to be sceptical of the health's ability to leverage real change around housing. But I think what we can point to is some points of material impact, and we've been working with specialist expertise in the housing sector to try and leverage some significant points of change, and the evidence suggests that we're doing some good work.
Okay, well, thank you, Richard. I'd welcome that information. Thank you. Well, thank you, Chair.
Thank you very much. I have Councillor David Keys, please.
Thank you, Chairman. Councillor Madden could do a lot worse than moving to Cow Plain, because according to the Office of Statistics, Cow Plain has the longest longevity of the highest income, the best employment figures, and the lowest teenage pregnancies in the area. So he moved there, he would have all the advantages.
Sorry, except the last one, thank you.
My question is probably for Richard. Richard, you're starting to look as though you need the same diet book as I'm on. I don't know what your good life is doing to you, but I'll put it down to COVID, I think.
Yeah.
Richard, you risk assessment in the hospitals, and in particular, I'm going to refer to QA. I know two people that have gone into QA for other reasons and have both sadly contracted COVID while they're in there and have passed away. I've also just heard of a case, and you mentioned it just now, Spire have also had a case as well. What are you doing to ensure that this doesn't happen on a regular basis? Because it appears at the moment as though it is.
Yeah, so I suspect I can give you a kind of headline update, and I really suggest if you want to get into it, we could bring a member of the infection prevention control team to give a really granular detail, because I fear, Councillor Keast, I would give you a headline view, and I can do that because we're constantly monitoring outbreaks and looking at the action plans, but there is some science behind it. So what do we understand about infection rates? And this is a learning process from the outset. So originally, we felt that the predominant cause of transmission of the virus in hospital settings was airborne droplets driven by coughing, and that was and therefore distance and good hand hygiene typically were the two key drivers for infection prevention and control. We've subsequently learned an awful lot about the importance of ventilation, critically, and airflow being major factors around infection prevention and control, and learning, particularly in older sites, how we've had to adjust and reduce the kind of occupancy of older sites in the light of understanding suboptimal ventilation and poor airflow, which has been a driver of IPC. So there's been a lot of learning around infection prevention and control in the care settings that have enhanced. Inevitably, when you come first contact with a new virus, it's understanding how the virus operates and moves. When you also get to a point of over 50% occupancy of any site, it remains a constant challenge, as you can imagine, of creating green and red separation. So green, non-COVID, red, COVID patient separation. So you, particularly with the new variant, which is now consisting of over 60% of cases now in Hampshire and the Isle of Wight, what we're discovering is, whilst we will continue to keep space, try and isolate red and green patients, create clean pathways, test patients routinely and regularly, and do lateral flow tests on all staff, and PCN tests on staff. We rarely are able to, irrespective of the highest levels of review, we will occasionally have outbreaks in our green settings, and then that requires us to move patients, isolate patients, and the like. So I think if I was a representative from the hospital setting here today, I would say this has been the greatest challenge around IPC, certainly in the last decade for the health sector, on top of unprecedented levels of demand for hospital acute care. And so every effort is made to test staff, to test patients, to keep space, to ventilate, to bring in airflow where we think there is poor airflow, and to isolate COVID patients and move them around. But even with that, there continue to be outbreaks, 1 or 2 patients contracting or passing the condition, and where those happen, there is a root cause analysis by the IPC team. Any factors that were not understood, was there transmission by staff, by patient, by guest, by another, and how can we continue to learn? But as I said, that's the kind of high level position. I would strongly advocate an IPC lead coming in and giving you the real science behind this, because it's a massively evolving piece, huge amounts of effort. I think the NHS will get there. I think the question that local authorities will want to have a look at is, much as we might want it to, COVID will not go away. We will see additional variants coming forward. Care home sector, schools, hostels and others are going to have to develop a fundamentally different approach to infection prevention and control in order to maintain safe and effective functioning of their conditions. So whilst hospitals at the front line, other sectors will inevitably have to face the same questions, which are, how do you prevent spread of infection within your care settings?
Richard, have you any idea of numbers at all for QA or South East Hants at all?
In terms of outbreaks?
Well, no, in terms of people that have gone in for other items that have come out with or passed away.
Oh, yeah. So we call these nosocomial infections. So individuals who present without infection and then develop an infection within a care setting. And I don't have the number on my fingertips, but we can send you confirmation of nosocomial infections across Hampshire and the Isle of Wight through to the committee. So we record this information, and I think it's in the public domain. So
I think probably the Portsmouth councillors would be very interested in that. I think. Thank you.
Thank you much. Moving on now to Councillor Arthur Agate, please.
Thank you, Chairman. Just there to get the mute off. David, can I suggest that you move out of Cap Lane and come along to Clanfield? Much nicer area. Chairman, a question for Richard. That was very, this is without doubt extremely complicated report, and my compliments on bringing it out. For us, this is item 6 on the agenda, so what may be your page 1 or page 7 isn't ours. But nevertheless, quick bit of counting, and I found out what you were talking about. The other thing was that you you went into detail on the amount of the oxygenating units or oxygen checking units in Portsmouth. What about the rest of South East Hampshire?
So is that the numbers of oxygenated beds or the oxygen?
No, the finger units that you were using for checking.
I don't. So Sarah, do you know? I'm not looking at the sheet of. I'm not looking at the report. Can you help me, Sarah?
Richard, the question is with regard to the number of patients on the virtual wards with the home oximetry. You referred to some Portsmouth numbers.
Yes, they're just Portsmouth. They're just Portsmouth City numbers.
So nobody else in South East.
Yes, I can give you the South East numbers as well. Bear with me. If someone whistles, I will give you the numbers within 30 seconds.
Okay. I can distract you for 30 seconds. I'll try my best. Our hospital does cover a slightly larger area than Portsmouth, taking in, of course, our neighbouring facilities. So
here we are. Yes. So we have 46 patients currently on the COVID virtual ward in South East Hampshire and Fareham and Gosport, and we have just over 100 patients in receipt of primary care pulse oximeters in Fareham and Gosport, South East Hampshire.
Thank you.
You're on mute, Lee. Technology. Thank you very much. I'm moving on to Councillor Graham Heaney.
Thank you.
Graham, you're also on.
I know, it just went off as I moved. There is reference in the document to the NHS's consultation, which apparently took place between the 9th of December and 8th of January, on how the ICS might be organised and what form it might take when legislation is brought in to formalise it. And I wasn't sure, one, whether other people have been able to pick up on this, because I didn't pick up on this until after the Christmas break. And I know Portsmouth City Council did put in a response to the consultation, and I've seen it, but I don't know whether other members have seen it at all. And whether, in fact, I mean, it's a bit late now, but it might be useful for us to have a copy of that we could see as members, because some of it obviously affects Portsmouth, but I'm sure it has other implications as well. And it's possible that other local authorities like Hampshire may well have put their own responses into the consultation, but I don't know about that. So my question really is, in the light of that consultation, how confident can we be that some of the things said here about things like the area base for planning and things like the assembly will be able to continue when some sort of legislative change comes in, or is this something that we just don't know what will be specified in any legislation?
So, so in actual fact, I think in reflecting on the documents that NHS England produced at the beginning of December and invited feedback via consultation on, all partners across the patch, including local authority colleagues, all of the NHS trusts and other colleagues that we linked in with, reflected that to some extent it felt as though we're actually ahead of the game, but in a positive way. That the direction of travel that we describe within the slides that we've included today is very much in the spirit of the proposed legislative changes. Certainly our work very much focused on what happens at that very local level in place, is very much supported by the proposals in the document. The level of involvement that we already have and the mechanisms that we already have in place to involve local people, if anything, offers something more robust than was described in the consultation document. So we were certainly very positive in reviewing where we are versus where the legislation might go. We felt that perhaps we're a little bit further ahead, and in our discussions with NHS England, we have all, I think in all of the responses, including the response you're referring to from colleagues in Portsmouth, we have all asked for more detail about what it is that NHS England might be proposing, might be suggesting, might be thinking. And we have all expressed a desire to be involved in conversations to support that thinking, because we, and I'm sure other areas across the country also, believe that we have some very sort of on the ground experience and useful proposals, suggestions as to how this could work, what it could look like in terms of legislative change. So we expect, for example, the specifics that you drew out there, we expect the Assembly to be something that sits very neatly and appropriately within the new legislative arrangements, assuming they are worked through and become legislation. And we expect our focus on developing services, making decisions at the most local level possible to be absolutely at the core of the legislative change as well. So we believe we're in a good place. We believe we're in a good place. And certainly some of the changes in terms of health commissioning, with the coming together of the various clinical commissioning groups across Hampshire and Isle of Wight, and very close working relationships with partners in Portsmouth. And City, from a clinical commissioning group perspective, again, all very much in the spirit of the consultation and the proposals that are coming through nationally.
Can I just come back on that? I mean, I don't know what the situation is in relation to the discussions that went on between Portsmouth and the other CCGs about whether to join or not to join. But Portsmouth took a decision not to. But the implication of the proposal is whichever one is chosen as one of the two key options which were put in the paper, is that the CCGs will go. In a sense, in Hampshire, it more sort of doesn't matter, if you know what I mean, because you've already integrated. But it certainly would mean that also CCG would disappear and would become part of the larger Hampshire ICS. Is that a correct interpretation of what the consultation says, as I've read it? I mean, that's what I understand it to mean, but I don't know if I've misread it.
So the consultation certainly implies that consolidated commissioning arrangements are favourable, preferred, proposed. Absolutely. The reality for us on the ground is that the working relationships between colleagues in Portsmouth and the rest of Hampshire and Isle of Wight are incredibly strong. And indeed, there may well be some legislation that takes that a step further from an organisational form perspective, from a structural perspective. There may well be something in the legislation that legislates, that mandates that organisations may need to come together more formally. But I think our perspective is that either way, relationships are strong, continue to develop, ways of working are in place, and again, will continue to develop. And if there is structural change required in the future, then that is something we will work through at that point in time.
I was just wondering if it might be helpful. I mean, we haven't got another meeting scheduled until June, and obviously there's lots of other things to deal with. That maybe might be helpful if we had some sort of an update on what the ICS's formal structure might look like in the summer, if there's any new information, and maybe get an update, because there's always that problem about the relations between what the structures are, which can be a bit boring and a bit technical, but what impact it has on the way services can be delivered and how you can work. And I think we need to maybe get our heads around how that's going to work. It may be good, but sometimes it's not always good, as we know from previous reorganisations of the NHS. It doesn't always work out as we think it will. So I'm just thinking that maybe at some point in the future, possibly in June, we might want to revisit this to see where it's going. In a sense, it's a suggestion I'm making.
Absolutely. I mean, I think certainly from our perspective, that would be very timely to have those conversations at that point in the year. We would expect to have work together with partners to develop the thinking around, like you say, the elements that may come across as rather technical and rather boring. So I think June would be the perfect opportunity to have those conversations and to further revisit where we've got to.
Thanks.
Okay, thank you much. I've not had any other questions notified on screen, and no one seems to rush and put their hand up. Thank you very much, Richard and Sarah, for coming in, presenting that and answering the questions today. So, moving on to item 7 on the agenda, we have the dates of future meetings for next municipal year. I've got 24th June, 16th of September, 18th of November, 20th of January and 17th of March. I'm going to take it, Councillor Steve Weems.
Yes, Chairman. Just wanted to say that I'm not re-standing for election in May, so this will be my last meeting unless...
Oh, we've got one more in.
There's one more.
Is
one
there?
more? Yes.
Oh, in that case, it's not my last meeting. I'll see you all next time.
Get to March.
Yes, so I'll take it by a sign of, unless anyone's objecting, I'll take it as a sign of consent for those. Oh, I've got another one from Councillor Arthur Gate. You're muted.
Thank you. Sorry, Chairman. 24th of June, Midsummer's Day. That's quite an important day for me. I may possibly need to give my apologies now.
Okay, yeah. Having worked for Scandinavian companies, I always find it sort of the Swedish and the Finns will never do anything on the Midsummer's Day. These could all change, of course, but they're the dates going forwards. But we'll show sign of assent going forward. The next meeting is scheduled for Thursday, the 18th of March at 1:30. I'd like to thank all the members and everyone who has done presentations today for attending. So I look forward to seeing you all at the next meeting on the 18th of March. Can we just wait for the live stream to be confirmed it's finished before we have any other conversations?
Right, I'll go and turn it off now. You'll still be audible for a couple of minutes.
Okay, thank you much. I apologise as well for any technical issues I've had today. I don't know why, but the laptop always decides it has to restart at